Hello everyone and welcome to our Community Behavior Change Project on condom use to prevent teen pregnancy in Knox County, Kentucky.
In order to identify what challenges we want to face or what behaviors we want to change, we must first assess needs, capacity, and resources for health promotion/education. Kentucky is leading the nation in many health/disease issues. While the state as a whole has made great strides in bettering health care, treatment, and preventative measures, health education is still very much behind the national approach. Kentucky has a population of 4.5 million people, reporting an average of 18.8 of individuals living below poverty level. Certain counties, however, have a much higher poverty rate, thus adding to the amount of health disparities and factors leading to poor health education and poor health in general. There are many factors that contribute to the overall health status of our state, such as socioeconomic status, availability of health care, health education, and environment. The factor that is most troubling yet has the potential to be the most helpful is the lack of comprehensive health education for students ages 15 to 19 and the effects that follow. The area we chose to focus on is Knox County. Knox County's poverty level is radically higher than the state average, which strongly correlates with higher levels of health issues. One particular health issue that shows a significant difference in county versus state average is the rate of babies born to women ages 15 to 19.
Knox County is a southeastern Kentucky county with a population of 31,883 of the last U.S. Census. Knox County is a rural area stricken with poverty, reporting 34.4% of persons in poverty with a median income of $26,000.
Knox County, Kentucky has several different community issues that contribute to teen pregnancies, one being that teens in Knox County have very little to do. Knox County is a relatively small county that offers very little safe, fun, and inexpensive things for teenagers to get involved in. In 2012, Knox County, Kentucky reported having 1,980 companies, with only 10 being classified as arts, entertainment, and recreation.
Knox County has 2 school districts with a total of 3 high schools. The school system in Knox County provides a thorough education in core classes such as math, English, science, and history. However, health education is not a class that is given a lot of time or attention. This can be attributed to state-mandated standardized tests in said core classes, and no government mandates or funds for comprehensive health classes, so they are not heavily focused on. The state average for teen pregnancy in Kentucky is 37 births per 1,000 women ages 15 to 19, while the state average in Knox County is 65 births per 1,000 women ages 15 to 19. Our goal is through making comprehensive sex education available, along with providing free, easily accessible contraceptives, we can promote and increase condom usage by Knox County teens.
Teen pregnancy in the United States. In the year 2015, 229,715 babies were born to women aged 15 to 19 years. The birth rate of teen pregnancy in the United States is 22.3 per 1,000 births. And again, Kentucky's teen pregnancy rate is higher than the national average with 37 births per 1,000. These statistics are proof of the lack of education and preparedness teens and parents have when it comes to safe sex in Kentucky. In 2010, taxpayers in Kentucky paid $158 million on teen pregnancy. Teens face many obstacles when entering into parenthood. Having a child is extremely costly when it comes to medical, everyday, and child care costs. Teenagers do not have the means to cover these costs because of the low-paying jobs available to them that fit their educational background and availability due to still being in high school. When planning for their future education, it is difficult to come up with the money or time to attend college classes or trade schools.
The social ecological model helps explain how behaviors are influenced by the environment and other factors. Starting from the center of the model is the individual. Individual level change strategy is the change to knowledge, attitude, skills, and beliefs of an individual. In this presentation, we are investigating to change one's attitude on condom use. The FAT Comprehensive Program, which is promoting health among teens, uses theory of reasoned action, social cognitive theory, and theory of planned behavior. This program improves awareness and knowledge about safe sex. The price of this is $679. Some outcomes of this program would be to help participants build negotiation, refusal, and problem-solving skills for practicing abstinence and condom use. The target population is all races, ages 13 or under, and 14 through 17, both genders, and in urban and rural populations. The program is delivered by discussion groups, games, role play, videos, modeling, practices, and homework. There are 12 modules. Each module is 1 hour and it consists of 12 days. The first module is Getting to Know You. This provides an introduction to the curriculum. It sets up a theme of proud and responsible behavior and asks participants to identify short-term and long-term goals and dreams. Module 2 is Exploring and Expressing Your Sexual Feelings. Module 3 is The Consequences of Sex HIV Infection. This increases awareness of participants' vulnerability to HIV infection and help increase knowledge about HIV and AIDS. Module 4 is A Plan to Reduce the Consequences of Sex. This introduces problem-solving techniques called Stop, Think, and Act, and begins to build negotiation and refusal skills for abstinence and condom use. Module 5 is The Consequences of Sex STD Infection. This focuses on increasing knowledge about STDs and to increase feelings of vulnerability to STDs. Module 6 is The Consequences of Sex Pregnancy. This is pregnancy prevention focus while addressing knowledge and attitudes about methods of contraception. Module 7 is HIV STD Vulnerability. Increases feelings of vulnerability to HIV and increasing skills to advocate for abstinence and safer sex. Module 8 is Risky Sexual Behavior and Content Review. This focuses on reinforcing STD and HIV knowledge and attitudes. Module 9 is Sexual Responsibility Abstinence Skills. This focuses on abstinence and targeting attitudes and skills to delay sexual activity. Module 10 is Sexual Responsibility Condom Use Skills. This focuses on how to use a condom and attitudes about condom use. Module 11, Enhancing Sexual Responsibility Skills. This continues to focus on negotiation skills and attitudes to support abstinence and safer sex. And the last module, 12, is Role Plays, Refusal and Negotiation Skills. This introduces a negotiation technique called Stop and provides opportunities for the participants to practice using the negotiation skills they have acquired throughout the program. This program would work well in Knox County because there is not a sex education program, and the FAT comprehensive program allows for a broader sense of sex education, talking about the different ways to be able to have safer sex.
The next level of the social ecological model is the interpersonal level of influence. This is made up by an individual's relationships with others, like their family, friends, and peers. Parents can be very influential in their children's behaviors by showing approval or disapproval and through communication or lack thereof. The Center for Disease Control and Prevention used this concept in one of their evidence-based interventions called Dating Matters. There are parent programs that help parents tackle tough subjects like safe sex and dating violence. The main focus of Dating Matters is to teach 11 through 14-year-olds healthy relationship skills before they start dating and reducing behaviors that increase the risk for dating violence like substance abuse and sexual risk-taking, which can cause teen pregnancy, the behavior we are looking to change in our program. Dating Matters has been successful in many cities around the country. One location Dating Matters has been implemented in is Baltimore. Their program has helped parents come up with ways to bring up the important conversations and feel more confident. One parent said, "I feel like not only it has empowered me, but it made me feel more comfortable with being uncomfortable. It gave me tools and conversation starters and topics that I can discuss with my kids that I might not have wanted to discuss before, but they do it in a way that helps me not be so uncomfortable. The Dating Matters parent programs provide parents of 6th, 7th, and 8th graders with skills that encourage positive interactions and communication with their children. This helps children be more trusting and open to talking to their parents about these issues. For parents of 6th graders, the program consists of 6 group sessions which are face-to-face. It's adapted from an existing evidence-based program to address dating violence. The program promotes positive parenting and effective parent-child communication on healthy relationship development and sexual health. This supports parents in sharing their values and influencing their teens' decisions about dating and sexual behavior. The structure of the program changes slightly for parents of 7th graders. Instead of 6 group sessions, they complete 3 face-to-face group sessions and 3 in-home self-directed activities that allow parents to practice skills learned in the group setting with their children. This program once again supports parents in using positive parenting skills, open and effective communication, and now appropriate supervision and conflict resolution. The structure of the program changes once again for parents of 8th graders due to more of them beginning to be in relationships. 6 booklets are mailed to parents to complete at home. These booklets help parents and teens explore different topics about dating violence together. This evidence-based program showed decreased risk of physical dating violence victimization. Being able to discuss sexual health and behavior can help parents get through to their children about the importance of condom use in preventing teen pregnancy. A contributor to the escalated teen pregnancy rates in Knox County is poor communication between parents and their children about safe sex. This program can help parents in Knox County evaluate their current approaches and learn new effective approaches to replace them with. Since so many of the population in Knox County live below the poverty line, and since homes are much more spread out, the location of face-to-face group sessions needs to be somewhere accessible, for example, a school. It could also be beneficial to have less face-to-face group sessions and more in-home self-directed activities, since it could be difficult getting access to reliable transportation. Incentives will also likely be important to convince people to show up. These could include gas or grocery cards or even raffle tickets. The age group targeted is perfect because it will impact young teens into making safer choices before they're between 15 and 19, when a lot of teens in Knox County get pregnant. Helping parents of Knox County teens feel more comfortable discussing these topics can impact their teens' behaviors, increasing condom use, and dropping the county's teen pregnancy rate.
Institutional and organizational level works to change policies that influence healthy behaviors at the institutional level. Be proud, be responsible, be protective works to reduce unprotected sex among sexually active teens, pregnant teens, and parenting teens. This happens by affecting knowledge, beliefs, and intentions related to sexual behaviors and condom use. The impact of HIV and AIDS on pregnant women and their children, preventing disease during pregnancy and the postpartum period is also addressed. Finally, the program references special concerns of young mothers. The program draws from 2 theoretical frameworks, social cognitive theory and theory of reasoned action. This includes 8 60-minute modules that cover the core content. Module 1 is Introduction to HIV and AIDS and their relationship to teen motherhood. Module 2 is Building knowledge about HIV and unplanned pregnancy. Module 3, Understanding vulnerability to HIV infection and unplanned repeat pregnancy. Module 4, Understanding vulnerability to HIV infection and unplanned repeat pregnancy, Part 2. Module 5, Attitudes and beliefs about HIV, AIDS, and safer sex. Module 6 is Attitudes and beliefs about HIV, AIDS, and safer sex, Part 2. Module 7 is Building condom use skills, and Module 8 is Building negotiation and refusal skills. These 8 modules focus on behavioral attitudes, expectations, negotiation and problem-solving skills, self-efficacy, and maternal protectiveness. Through these sessions, the program provides participating teen mothers with medically accurate and factually correct information on HIV/STDs and pregnancy prevention. It also addresses behavioral attitudes/outcome expectancies, builds negotiation and problem-solving skills, builds self-efficacy and confidence skills such as positive reinforcement, support, and constructive feedback, and focuses on enhancing feelings of maternal protectiveness, including educating youth about the effects of HIV on child and family and the strengths and challenges of early parenting. The methods this program relies on: facilitator modeling, role-playing with feedback, films, group discussions, writing, and skill demonstration to deliver its content. It was evaluated in 4 schools in Los Angeles County. After 12 months, adolescents reported having fewer sexual partners in the past 3 months. The study also examined program impacts on measures of AIDS knowledge, intentions to use condoms, self-efficacy, attitudes, maternal protectiveness, and social desirability. The program also added allowable adaptations. The program may be implemented in a larger group setting, but participants should be divided into groups of 6 to 8 for some activities, and the small group should be brought together to share their discussions and results. The program can be implemented in community settings such as youth serving agencies. Agencies can structure the program sessions in the following 4 ways: 8 days of approximately 1 hour per day, 4 days of approximately 2 hours per day, 2 days of approximately 4 hours per day, 1 day, a Saturday is preferable, for approximately 8 hours plus time for serving lunch and snacks. We selected this program for Knox County because their teen birth rate is almost double the teen birth rate in Kentucky. We found it important to not only work to prevent these teenagers from getting pregnant, but also to protect them in case that does happen. They can be altered to implement this in Knox County by acquiring a DVD player and TV monitor, splitting the large groups into groups of 6 or 8 for certain activities, but allowing the groups to come back together for full discussion. We decided that implementing the program over 4 days for 2 hours per day would be the best way to implement it, so students weren't overwhelmed with too much information. We also said that including a health educator to teach the information to students would be preferable so that they can answer their questions. The review team conducted an independent assessment of the program's readiness for implementation. This assessment is based on the team's review of available program materials and documents. They also requested input from program developers and distributors about the availability of implementation materials and resources. The basis of this assessment, the team calculated an implementation readiness score comprised of 3 component scores. 1 is curriculum and materials, 2 is training and staff support, and 3 is fidelity monitoring tools and resources. The component scores are combined into a total score which ranges from 8 to 0, with higher scores indicating the program's most ready to implement. For curriculum and materials, they ask that you have defined curriculum with plans and/or activities, defined core or required components, and has facilitator's guide or instructions. For training and staff support, they ask for formal pre-implementation training by qualified trainers to be available, supplemental training or ongoing technical support available, and then for fidelity monitoring tools and resources, they has a defined logic model, defines fidelity guidelines and benchmarks, and offers monitoring and evaluation tools.
The implementation of the Be Proud, Be Responsible, Be Protective program consists of 8 60-minute modules which can be delivered over 1 to 8 days. The ideal group size is 5 to 15 participants per facilitator. The program was evaluated with professional nurses serving as facilitators, but trained educators and social workers may implement the program. Facilitators should have experience working with pregnant or parenting teens and familiarity with the issues that affect sexual risk-taking in this population. 1 facilitator is needed for groups of 5 to 15 participants to enhance quality of interactive and skill-building activities. Developers also suggest that staff demonstrate a caring and supportive attitude, be highly participatory, and use interactive skills. Program materials and resources that are included in the Be Proud, Be Responsible, Be Protective kit comes with 1 facilitator curriculum, 2 activity set, posters, role plays, and interactive cards, and 3 6 curriculum DVDs, which include a story of Tanisha and Shay. The subject is HIV. The subject is STDs. He Said He Loved Me, Baby Talk, Wrap It Up, and condom use animation. Additional needs that were mentioned in the presentation were that the program requires the use of a DVD player and TV monitor. The staff and training support includes a highly recommended educators who plan to teach, be proud, be responsible, be protective, receive research-based professional development to prepare them to effectively implement and replicate the curriculum with fidelity for the intended target group. Training for the Be Proud, Be Responsible, Be Protective program is available through ETR's professional learning services. ETR provides in-person and web or phone-based technical assistance before, during, and/or after program implementation. TA is tailored to the needs of the site and is designed to support quality assurance, troubleshoot adaptation issues, and boost implementation. Adaptations were also mentioned in this recording that the agencies or when programs are deciding to use this program can be presented in 4 different ways: 8 days of approximately 1 hour per day, 4 days of approximately 2 hours per day, 2 days of approximately 4 hours per day, or 1 day, preferably a Saturday, for approximately 8 hours plus time for serving lunch and snacks. As mentioned in the presentation, we recommend that Knox County schools implement this program for 4 days at approximately 2 hours per day as to not overwhelm the students with too much information.
Adolescent Health Teen Pregnancy Prevention Program is a national evidence-based program that funds diverse organizations working to prevent teen pregnancy across the United States. The program was funded by Congress in 2010 to create age-appropriate and medically accurate programs. According to the Office of Adolescent Health website, the program invests in the implementation of programs that are evidence-based. The program also invests in the development and evaluation of new and innovative approaches to teen pregnancy prevention. The program reaches individuals aged 10 through 19 while focusing on areas across the United States with the greatest need of reducing teen pregnancy. During the first 5 years the program was funded, 102 grantees reached 500,000 youth. More than 6,800 professionals were trained, and over 3,800 community-based organizations were established with partnerships. The TPP program also funded 41 evaluation studies that contribute to the field's knowledge of where, when, and with whom programs are most effective. The Office of Adolescent Health Teen Pregnancy Prevention resources made available to communities include free training, e-learning modules, webinars, and technical assistance. These resources are provided to help implement high-quality and engaging programs. Knox County can use the TPP program to create community-based activities. The program's outline and available resources can assist in program development and implementation. These programs will focus on increased condom use and sex education in order to decrease teen pregnancy countywide. An example of a community-level program is the Better Family Life Incorporated in St. Louis, Missouri. Better Family Life Incorporated, or BFL, hopes to reach nearly 20,000 middle and high school students in 28 zip codes in St. Louis by 2020. Better Family Life Incorporated implements 3 evidence-based programs: Making Proud Choices, Promoting Health Among Teens, Abstinence Only, and Sisters Saving Sisters. The program works with poor urban communities and partners with 22 public and private schools in St. Louis. By 2020, Better Family Life Incorporated Teen Pregnancy Prevention Program expects to see positive results in the community they serve, including reduced rates in teen pregnancies, teen birth rates, and sexually transmitted diseases. This program is an example of what the Office of Adolescent Health Teen Pregnancy Prevention can assist in while implementing and developing a community's own program. Like Better Family Life Incorporated, an evidence-based program funded and implemented by the Teen Pregnancy Prevention Program could provide services in communities like Knox County with the greatest need. while also instilling awareness among students and parents about sex education and condom use, and serving as a partner across the county. Although St. Louis and Knox County are different demographically, they both experience the same need of reducing teen pregnancy rates. One of the programs St. Louis is focusing on includes teaching abstinence only, which was something that this area had been able to use effectively for their community. However, Knox County is currently using abstinence as a way of preventing teen pregnancy, and it is not proven to be entirely effective. Further research has shown that abstinence-only sexual education in Knox County high schools has resulted in a teenage birth rate that is almost double the teenage birth rate of the state of Kentucky. While creating a program for Knox County, it is beneficial to look at the background research and use it to build a tailored program that would be effective. A program like St. Louis's can help researchers for this new program to know what aspects have worked and what have not worked in order to be successful. Implementing previous successful research aspects can result in a program that works effectively for the current target audience and can decrease the teenage pregnancy rates while increasing condom knowledge and usage in Knox County.
The societal/public policy level of the social ecological model focuses on local, state, and national laws and policies that create the built environments and systems related to the model's topic.
In order to promote condom use among teens, they need to be properly educated on 1, how to use a condom, and 2, what could happen if they don't. Unfortunately, Kentucky's legislation is doing nothing to promote safe sex and condom use. Current legislation states that schools should adopt an abstinence-only curriculum into their sex education. The bill reads, "Curriculum for human sexuality or sexually transmitted diseases. Instruction shall include the following content. Abstinence from sexual activity outside of marriage as the expected standard for all school-aged children. Abstinence from sexual activity is the only certain way to avoid out-of-wedlock pregnancy, sexually transmitted diseases, and other associated health problems. And the best way to avoid sexually transmitted diseases and other associated health problems is to establish a mutually faithful, monogamous relationship in the context of marriage." This legislation does the opposite of what it was intended to do. By not informing teens about sex and how to be safe about it, you are only harming them. The subjective norm of sex is to not talk about it. But statistics show that no matter how much the school system teach abstinence only, teens are still having sex. In order to change the behavior, we need to target the subjective norm. We can do this through the theory of reasoned action. Through this model, we would be able to stress the importance of comprehensive sex education to legislators, educators, and parents. In order to fully understand the societal attitudes towards sex, the behavior, we would host community forums either online or in person that would encourage the community to voice their comments or concerns. After learning those concerns, we could present the community with the actual facts facing their county and then show them studies of areas similar to them and what worked together to target that problem. After all of this, we would then report findings to Kentucky legislation and propose the implementation of comprehensive sex education and contraceptive use into current sex education curriculum. Change the subjective norm and behavior through the theory of reasoned action. Like I mentioned, we could host community forums that let parents voice their concerns about current sexual education offered in schools. We would then report those findings to local legislators. That would propose a bill that would allow comprehensive sex education and contraceptive use to be implemented into curriculum. And then we could also work with local health departments to implement programs that stress the importance of comprehensive sexual education. This hopes to change the attitude that society has about sex education.
Based on the most effective research discussed in this presentation, a combination of these has resulted in a program that aims to assist in increasing condom use and preventing risky sexual behaviors that could result in teen pregnancy. The program implemented will include an educational session for teens and parents, increased self-efficacy about safe sexual practices among teens in Knox County, increased awareness of the consequences of sexually transmitted diseases and pregnancy, provided educational resources to the community to assist in program development, increased access to contraceptive resources in the community, a policy that allows for comprehensive sexual education in Knox County schools. Within the next 5 years, the program will be established across Knox County schools and will attempt to meet the following objectives. After 1 full year, the program will reach out and educate 25% of parents with teens on how to talk to their teens about sexual health and education. By the end of year 2 of educational sessions in schools, 75% of students will be able to identify 4 risk factors of sexually transmitted infections in teen pregnancy. By the end of the 4th year, we will increase the availability of free contraceptive resources and information to students by 60%. After completing the educational sessions, half of students will be able to identify at least one of their habits that could lead to teen pregnancy or sexually transmitted infections.
Statistics and information for this presentation were found at the following: U.S. Census Bureau, Kentucky Health Facts, Kentucky General Assembly, Office of Adolescent Health, U.S. Department of Health and Human Resources, Center for Disease Control and Prevention, and the U.S. Department of Health and Human Services.